What I'm going to present tomorrow is it's not meta-analysis. What we've done is we've combined the data on the 3 trials involving single-agent Ibrutinib in patients with relapsed refractory mantle cell lymphoma. So that's 370 patients altogether. And what that allows us to do is look at the response by baseline criteria, characteristics, and duration of progression-free survival and overall survival. What we previously knew was patients respond to Ibrutinib, about 70%, and we knew that every single type of patient would respond. What we've done here is we've looked at response by progression-free survival and overall survival rather than response rate. And you see some pretty impressive differences. So for example, when you use Ibrutinib as first-line treatment, as first relapse, you get a hugely more significant improvement in PFS and overall survival than if you use it in second line or third line or beyond third line. And that translates into overall survival as well. The other thing we see is, this is probably the most dramatic result, is if you look at complete remission, so patients that get complete remission on Ibrutinib, the duration of that response is extraordinary. So 92% of patients are alive at 2 years who get a CR on single-agent Ibrutinib for relapsed refractory disease. So the patients that respond get really very impressive responses. The other thing is, if you look at baseline characteristics, so patients who we know have bad features of mantle cell lymphoma, blastoid variant, bulky disease, high MIPI score, that group of patients do worse. Bulky disease, so all the things we know are bad prognostic factors in mantle cell lymphoma, you don't see that with respect to response rates. All those patients respond the same way, but their progression-free survival is far inferior to the patients that don't have those baseline characteristics. So I guess what I'm saying is people with bad disease do badly. They do better than any other drug, but they don't do as well as people with good prognostic factors. And the real take-home message is, if you're going to use the drug, use it early. Using it first relapse is completely different than using it later on. You get much better responses. And of course that begs the question, if you use it at first relapse, is it better if you use it front line? And of course there are a couple of trials, including one I'm running in the UK, asking that very question. And you might imagine that using it front line it will be better than using it at first relapse. We'll see.